Hello and welcome to the Processes and Documentation in the Anaesthesiology module. Let's begin with admissions. This will be the core tasks required from you, and having good documentation skills and clerkship skills are going to be an advantage throughout your training here. The skills you'll acquire during the basic clerkship in anesthesiology are broadly applicable to a wide variety of fields and are particularly useful in rapid response and code situations. So as a house officer on the basic rotation, you are encouraged to be an active participant in your patient's anesthesia care from start to finish, conducting the pre-operative evaluation prior to induction, to performing procedures during and after induction, finally to signing out to the pediatric admission care, acute care unit after emergence. So anesthesia rotations are not just shadowing, you will be encouraged to get your hands dirty as well. You will receive one-on-one teaching in the operating room from the anesthesia residents and attendings who are engaged, active teachers, and who view you as an integral member of the team. As you can see here, the admissions to the intensive care unit is generally from the wards, operating theatre, the emergency room, as well as direct transfers from other hospitals. So as a house officer here, you play quite an important role in clerking patients' history, performing exams, ordering investigations such as lab works and imaging studies, and basically you will need to ensure all orders are carried out accordingly as well. Admission clerking, as the name suggests, is carried out for the patients who are admitted to the ICUs, and the house officer in charge here of the new patient being admitted is expected to review the patient within 30 minutes from the time of admission. Review the clerking which was done early in the clinic, emergency department or periphery, and have an idea of the case you might be dealing with to be able to revisit the history and fill up any more information left. Review the observation chart to ensure the vital signs are charted and within acceptable ranges. If the vital parameters are abnormal or if the patient is in any form of distress, alert your medical officer or anesthesiologist. Generally, in the intensive care unit, the vital parameters are all real-time and they are seen in the monitor that's quite big and available in the ICU. From the emergency department, usually your medical officer would receive a call from the ED medical officer, and sometimes you may be in charge of the ED referrals for that day. So you may have to see the patients in the ED first. Therefore, you will need to do a detailed clerking, perform necessary exams prior to your MO's arrival. So in cases where the MOs are available, they would just go along with you to review the patient. Generally, the patients that you see in the emergency room would be the ones in the resuscitation zones or red zones where either they require mechanical ventilation and or they have critical illnesses that are life-threatening. And here to gather more history, you will need to speak to the family members or next of kin or probably refer to the previous documentation and findings of the clerking doctor. The patients from the operating theatre sometimes may require admission to the ICU if they require critical care until they are stable to be transferred to the general wards. So here you will be in charge of gathering the intra-op and post-operative notes and documenting them well prior to handing them over to the doctors who are stationed in the ICU. And sometimes resuscitative care needs to be given in cases which require them in the OT itself. So you'll be assisting your medical officer and anesthetists in carrying them out. Not forgetting, as elective procedures are planned way much ahead, don't miss your chance in performing endotracheal intubation and other interesting procedures such as spinal anesthesia delivery and many more in the OT. So how about patients from the periphery wards? Well, the patients from the peripheries, also called as ward referrals, may or may not be transferred to the ICU, but a full clerking may be needed as soon as you review the patient. Most of the time, the referrals to the ICU or NS team is for resuscitation and endotracheal intubation. Be prepared with the equipment which the wards may not have prior to arriving at the scene. Here, preparation is key. Now, let's move on to case presentation. So, you'll be routinely required to present cases in the intensive care unit, and it's important because it is a formal way of communicating between healthcare professionals regarding the patient's clinical information. So again, just like every other department, you will begin your presentation with an opener. You should begin every oral presentation with a brief one-liner that contains the patient's personal details and the reason for hospitalization. So remember, in this setting, you may not have a patient who is able to communicate with you as he or she might be in critical state. Receiving the information well from the previous or referring team is very important. Let's move on to the history of presenting illness. Here, you will need to gather and elaborate on why the patient sought medical care and what transpired until the current state. Describe the events that preceded the patient's presentation in chronological order. Next would be finding out the past medical history to identify if there could be any correlation to the current presentation. And this would include the patient's past medical condition, past surgeries, as well as medication histories and current prescription and allergic history. Not forgetting family history, because some life-threatening or very ill conditions can be related to a family inheritable condition. Social history. This will be important because this section would include the patient's living situation, occupation, their alcohol or tobacco use, any other substances, and also understanding the socio-demographic background that the patient is coming from. Having completed your history taking, you then move on to physical exams, and here you would do a thorough physical examination in the ICU together with certain bedside tests or scans that will be carried out by your medical officer or anesthetist to identify the severity of organ impairment or if there's any response to fluid resuscitation or boluses. Having compiled all this information from the physical exams as well as the bedside tests, we can then proceed on with identifying the tests that's required in order to diagnose and assess the severity of the patient in the ICU. So here you will be in charge of ordering the bloods as well as dispatching them if the medical assistants are not available. Then we have finally the plan. So this is the most important part. You should conclude your presentation with the assessment and plan. And this is the important part of your presentation. It gives you the opportunity to show your team how much you have learned. Next would be the progress reviews. So all patients will require progress reviews. These can be patients from the ICU or patients in the periphery ward who has been referred to the anesthesiology team. This means you will need to review the patients according to whom you are assigned to. The reviews may be twice or thrice a day depending on the current load of the patients, and you will be assigned to certain beds or cubicles in the ICU. Your work usually starts at 7 a.m., but it could be definitely better if you come in earlier to review your patients prior to the morning rounds. So what you need to know here would be the progress and the current issues of the patients from the day the patient is admitted to the ICU until you see them in the morning. There are a few tips to speed up your understanding of the case before you begin your review. So ask yourself, why is the patient in the ICU? How many days is the patient in so far? How many days has there been a surgery or post-operation if there has been one? How is the wound or how is the patient's progress until date? And what have we done in terms of tests and treatment? And finally, what are the future plans and impending results? So reviews are done usually 3 times a day by the house officer in charge unless an emergency sets in. So you have got your AM review, which is done between 7 to 9 a.m., your PM review between 2 p.m. to 4 p.m., and your on-call review between your 8 p.m. to 12 a.m. So once you have done your reviews, you've got to present your review findings to your medical officer, who will be also doing their rounds around the same time. And there might be some changes or additions to your review. Document them promptly so that nurses will be able to carry out their part of the plan as well. Next, let's take a look at handovers. So handovers occur when a house officer hands over the responsibility of care of a patient to another house officer. In fact, handovers occur at every level of care, from the consultants, specialists, and even amongst nurses once their shift ends. So as a house officer, you will need to follow a well-devised format of handover to ensure pertinent information regarding the patient is not missed and to avoid wrong information passed over. Past events, which means details of what has been done for the patient as well as the progress for the day before. Present plans and events, which includes details of plans that have not been carried out. And future events would be details of upcoming plans given by the specialist or the medical officer. When service from another department is required, a request is made. House officers are assigned to make requests following the plans in the daily reviews. So how does a request work? Identify what is the test to be done, identify the departments involved, and also the officer in charge, outline the purpose of the request and the urgency for the test to be done, how the test will be able to aid the diagnosis and the management of the patient, and finally identify the criteria that's needed for the requested test, such as if you were to request for a CT scan from the ICU, generally you will have to ensure that the patient has a good intravenous access for contrast administration, probably hydrated prior to the test. If the patient might need sedation because the patient has not have full GCS and may be aggressive, and also documentation that needs to be filled out. So to place the order or request, you complete the request form for the test, you call or meet the medical officer in charge of receiving the test. Once granted, inform the ward nurse on the plan to transport the patient over to the location of the test and document the trail as to who granted the test, when the test is planned for, and the preparation steps for the patient. Now, these are examples of tests that may require verbal requests, such as reportings, maybe CT scans and MRIs, group safe and hold or group cross-match, urgent full blood picture, as well as an echocardiogram in the ICU. And as for tests that do not need verbal requests, examples would be the basic routine blood tests, radiographs, as well as non-controlled medications. Now, let's move on to referrals. Referrals are made to other departments for their management input or suggestions, or if their skill sets are required in the management of the patient. So here, the role of a house officer is to, first of all, understand and identify the purpose of the referral, identify the departments that will be involved, identify the officer in charge of the referral, and finally, to call the officer in charge and to document the trail as to which time it was being referred, the indication, and the officer who accepted the referral. Let's see an example of a referral that's done on the phone to the medical department from the anesthesiology department. So you always begin with communicating clearly and confidently when you're introducing yourself. You can say, "Good morning, Dr. So-and-so. I am Dr. Betty, house officer from the anesthesiology department. I would like to refer Mr. Y in our unit for dialysis support." So here, you will want to state clearly the patient's details as well as the reason for referral in the first opener. This is to ensure that the person receiving the referral will be able to channel their thoughts and gather the required information from you in order to make a decision. Now, finally, we have discharge summaries. So how does a discharge work in the ICU setting? Generally, hospital discharge summaries serve as the primary documents communicating a patient's care plan to the post-hospital care team. So often, the discharge summary is the only form of communication that accompanies the patient to the next setting of care. However, here in the ICU, the discharge may include discharge from the review by the ICU team or NS team in the periphery wards, or the emergency department, or a discharge summary is also carried out once the death is issued in the ICU. Discharge documentation are generally carried out by the primary team managing the patient. So the final part would be to alert the primary team on the demise of the patient, or if the patient has been now transferred to another hospital, hence a discharge needs to be done, to assist with the documentation, to prepare the discharge summary or note, and as well as assisting in conveying the bad news to the family if a demise has happened. So the final part here would be alerting the primary team if the patient has already passed on, or if the patient is being planned to transfer to another hospital, hence a discharge needs to be done, to assist with documentation, to assist with the discharge summary and note preparation, as well as to help convey the bad news to the family if there has been a demise. So we have come to the end of this session. We hope it was insightful and thank you for your time.